Good morning, everyone. My name is Maya Luria with TMC for Seniors. And today we're going to be talking about when surgery is the best option, understanding common procedures in older adults. I have Dr. Caroline Butler here with me. She is with our TMCOne General Surgery. How are you today, Dr. Butler?
I'm great. How are you?
Good, thank you. I want to just share a little bit about you before we get started. Um, Dr. Butler has been a healthcare provider who believes in transparency and open communication, which are key in a doctor-patient relationship. She's inspired by her personal life experiences with illness, and she recognizes the effect of illness and injury on her patients. You are originally from Bethesda, Maryland, and you earned your medical degree from the University of Maryland School of Medicine. After completing your general surgery residency at Georgetown University and a fellowship in trauma and surgical care, critical care at the University of Miami, Dr. Butler moved to Tucson. And I know you came to be closer to your family, and you love the sunshine, right?
I do. Yeah.
And we know we have lots of that here.
And no humidity.
Exactly. So anyway, we are good, except for, hold on just a second. I just realized your PowerPoint seems to have gone missing here on my screen. Okay. So hang on just a second. I apologize. I'm just noticing it was up, but it appears to have disappeared here. Okay, great. I've got it now. We are going to go ahead and get started. I will turn it over to you, Dr. Butler. So thank you so much again.
Thank you, Maya. Can everybody hear me? I think the mic is not working. So just let me know if I need to project a little bit louder. But yes, thank you for that introduction, Maya. I am trained in trauma critical care, but I do general surgery here. So I'm going to talk about some of the more common general surgery procedures or issues that I frequently see in clinic. My clinic is just right over here on Wyatt on this campus, and go over some of the questions that I get, pretty frequently from my patients. So in terms of surgery for seniors in general, surgery is definitely considered still a vital intervention for a lot of conditions. I know, sometimes older individuals can have concerns like about anesthesia or undergoing surgical procedures, but oftentimes surgery is the best solution, and it may be the solution that leads to the quickest recovery and the best outcome. So it's important to understand when is it indicated, and, when is this something that potentially I could observe and manage non-surgically. And in terms of older adults, there are a lot of unique concerns, obviously. You may be on a number of medications, blood thinners, things that make surgery more difficult. You may have underlying medical conditions that complicate surgery. So all of this is important to consider when you're talking to your doctor about some of these conditions. But it is important to know, like I mentioned, surgery has come a long way in the last 40 years, even the last 5-10 years. We've moved to doing a lot more minimally invasive surgery, and so oftentimes recovery from surgery is a lot quicker than people tend to expect. So all of this basically means that I think it's important to have a conversation with your surgeon and kind of discuss what your priorities are and what the various options are and what the best option is for you in particular. So just some general principles about surgical management. A lot of these conditions that I'm going to discuss, there is an option to treat them non-surgically with medications or some lifestyle changes, things like that. But, that may not always be the best solution for you. Especially when you're thinking about quality of life. I think, especially these days, I don't actually know the data on this, but I think, life expectancy has lengthened quite a bit. And so you could be looking at having another, 20, 30, 40 years of life that you want to have a good quality of life. And sometimes surgery can be a part of that. And oftentimes in older individuals, especially if you do have some underlying medical problems, it can seem counterintuitive, but sometimes surgery actually is better because having a complication of a disease, that is left untreated can actually be worse than the surgery itself. So we'll discuss some of that too. So this is obviously not an exhaustive list of conditions, but these are just what I'm going to focus on today because they're some of the more common things that I see in clinic for older adults and for younger patients as well. But gallbladder disease is a big one. That's probably one of the most common things that I see. Hernias, mostly inguinal, abdominal wall hernias, umbilical hernias, things of that nature. And then I'll touch upon diverticulosis and diverticulitis, because I do see that quite commonly as well as appendiceal disease. That one's pretty straightforward. And then we'll just end with skin and soft tissue lesions. Those are also pretty straightforward the vast majority of the time. So gallbladder disease, has anybody here had their gallbladder removed? Okay, not as many as I would have thought, but so gallbladder disease is very common in people of all ages. I think it's the most common procedure that I do, and probably the most common condition that I see overall. The most common thing is just gallstones, and I would say we don't even know what percentage of Americans actually have gallstones. It's probably much, much higher than we think, because not everybody is just walking around getting ultrasounds of their gallbladder. So I would say probably a large majority of people have gallstones at baseline. The problem with gallstones is when they start to cause symptoms. And we'll talk about what those symptoms are. There are a lot of risk factors for gallbladder disease, gallstones. You can see some of them here. Increasing age, obesity are big ones. Being female, which I see everyone in this audience right now is female, just puts you at higher risk at baseline. That being said, I see plenty of people who have none of these risk factors and they have gallstones. So it just sort of is what it is. And then, like I mentioned, the symptoms of gallstones or gallbladder disease, most typically people will say, well, after I eat, especially if I eat something really fatty or greasy, I will get pain right up here under the rib cage on the right side, usually shortly after eating. And it can be severe to where you're having cold sweats, nausea, vomiting, sometimes even. And what we call symptomatic gallstones, to where it's just a gallstone causing the issue. You're not having any underlying infection or inflammation. Typically that pain will last for an hour or two and then subside. And, so oftentimes people won't seek emergency care or go see their doctor the first episode. They'll say, oh, that was weird. I don't know what that was. And when you'll start to see that you'll have recurrences. So it will start happening, once a month and then once a week. And then sometimes it gets to the point where every time you eat, you're having pain. And so obviously at that point, hopefully you have seen somebody and been referred to a surgeon or had a study. Typically, when I hear a very typical history like that, I can pretty much tell you it's going to be the gallbladder. But in most cases, your doctor, if you're just seeing your primary care surgeon, your primary care doctor first is going to order an ultrasound of the gallbladder just to see whether or not there are stones. I do have people come to me because they were getting imaging for another reason, a CT scan, an ultrasound or something, and it shows that they have gallstones. And so oftentimes they get referred to see a surgeon, and they come see me and say, I have no symptoms whatsoever. Like, I don't ever have any pain here. I don't have nausea, vomiting. I'm able to eat whatever I want. And that's what I would call asymptomatic gallstones. And so for asymptomatic gallstones, we do not recommend surgery for that, because there is a high likelihood that you could just have those gallstones and never have a problem with them. So definitely if you have incidentally noted gallstones and no symptoms, the recommendation is not to do surgery for that. if you are having any sort of symptom, like I just explained, especially these classic symptoms, if I were to see you in clinic, I would say, yes, I do recommend we go ahead and remove your gallbladder electively. Because the risk is that when once you begin to have symptoms, they're most likely not going to go away. They're probably going to get worse. And like I said, more and more frequent. And at some point, you can develop a complication like an infection of the gallbladder, or what we call acute cholecystitis, which is essentially where you have an acute attack of your gallbladder, and you get a pain that is persistent and doesn't go away. And that is what usually brings people to the emergency room. They'll say, okay, I've had this pain now for 10 hours and it's not going away. And so, you'll go to the emergency room and most likely have some sort of imaging there that will show that the gallbladder now not only has stones, but has also some sort of, indication that it's just angry. It's very thickened, there's fluid around it, and things like that. And we like to avoid getting to that point if possible, just because one, that's going to require an inpatient admission versus just doing an outpatient gallbladder removal. And it's also just, it makes the surgery more complicated when there's a lot of inflammation or infection. The risks are slightly higher. I mean, that being said, if you go to the ER with acute cholecystitis, it's not the end of the world. Surgeons are used to doing gallbladder removals for cholecystitis, but we always like to get to it before it gets to that point. So once you start having those symptoms and you have stones, it's best to get a referral to see a surgeon to talk about having an elective removal of your gallbladder. Because like I said, when we are doing these electively, it is outpatient. So you can come in, go out the same day. It's with any surgery, there's a risk, but this is a very straightforward surgery. Recovery time is pretty quick if we get to it early. So this is definitely a condition that you do want to, take care of. And I would say at pretty much any age. I mean, because your quality of life is going to be significantly affected if you're unable to eat experiencing frequent episodes of pain every time you eat. Some people do ask, are there medications I can take to get rid of the gallstones? And the answer is no. The gallstones will always be there. There's no medications. There's no lithotripsy or anything the way they can with kidney stones that you can do. Some people, if they're very against having surgery, would say, in some of those cases, I would recommend sticking with a very low-fat diet, and you may be able to manage the symptoms that way. But, for most people, that's not going to be feasible just to stick with a completely fat-free diet all the time. So I would say in the vast majority of cases, I would recommend a surgery for any sort of gallbladder disease. Sometimes I do see patients who have sort of vague symptoms. They're not those classic gallbladder symptoms that I described. It'll be, pain, in other parts of the abdomen, or, maybe just some nausea or inability to tolerate certain foods. And sometimes when, the symptoms are not classic and I'm not convinced that it's the gallbladder, I will recommend maybe a period of observation and maybe some lifestyle changes, or, further workup to see if it could be something else prior to suggesting a surgery. Even though this, like I said, is a fairly straightforward surgery, it's still a major surgery. So only in those instances when the diagnosis is not clear will I maybe recommend holding off on surgery. So I don't know if you all know the anatomy of the gallbladder, but essentially it's this little green thing here. I don't know if there's is there a pointer on here?
It doesn't read on the TV.
Oh, it doesn't? Okay. So, and people always ask me what the gallbladder does. Essentially what it does, your liver makes bile and it excretes the bile into these ducts, and then it goes into your gallbladder. We call it the gall bag sometimes, and it just gets stored there. And then every time you eat, particularly something fatty, your gallbladder contracts and squeezes some of that bile out into your intestine. to help digest the fats in your diet. So that's why eating really fatty foods can really exacerbate the gallbladder, because, you know, it's then prompting it to contract, oftentimes against a stone that may be stuck there. So when we remove the gallbladder, you know, essentially what we do is we go in and we clip across that duct, and we just, you know, the gallbladder is connected to the underside of the liver, so we do have to remove it from there, and we put it in a bag and just pull it out of a little hole about this big. So we did talk about the symptoms. Yeah, we talked about the benefits, just preventing further complications, improving quality of life. After surgery, like I mentioned, for most people, recovery is very quick because this is done so minimally invasively. You know, by the next day, you should be up walking around, back to your normal routine. You can eat and drink normally. The one thing that I occasionally do hear people say is that they can have some digestive issues after gallbladder surgery for a short period of time, usually diarrhea or loose stools, because, like I mentioned, the gallbladder does kind of aid in the digestion of fats in your diet. So if you eat a really fatty meal right after your gallbladder has been removed, some patients will find that they have loose stools or diarrhea. That's not everybody. Some people notice no difference at all. So it varies from person to person. But that's really the one thing that I do find some people say. But typically that can be managed once your body sort of adapts to the change, and you can sort of figure out, okay, you know, if I have a hamburger and French fries, that's probably not going to agree with me. So, and I do find those symptoms over, you know, a period of months tend to resolve in the vast majority of people. Okay, so let's move on to hernias. I say this is also an extremely common condition that I see, all types of hernias. The most common being inguinal and umbilical hernias. The inguinal hernias, I don't see any men here. Like I said, they're much more common in men, but they can happen in women as well. You know, so, but the vast majority of the patients I operate on for inguinal hernias are men. Umbilical hernias or ventral hernias would be hernias that are occurring somewhere on your abdominal wall. And you can also develop hernias at sites of previous incisions from previous surgeries, what we call an incisional hernia. And so, you know, our goal, of course, with these hernias, again, is to improve quality of life, because they can be quite debilitating, and to prevent serious complications from developing from the hernias. So when do you need surgery for a hernia? And this applies to all kinds of hernias, incisional, inguinal, ventral. But essentially, if you're having any sort of symptom from your hernia, a repair is likely indicated. So pain, discomfort, if it's interfering with your daily activities, you know, you're not able to walk or do the activities that you normally do, that is an indication to go ahead and have your hernia fixed. Also, if you notice it's enlarging, because typically what you'll notice is, you know, you have a bulge. A lot of times people will say, okay, well, when I lay down, it goes back in, or something like that. But if you notice over time that bulge is enlarging, it's best to get it addressed sooner rather than later as well. And the concern for these hernias, you know, is that they can develop pretty severe complications. So what we call either an incarceration or strangulation, because I think this is really small, so I apologize, but essentially what a hernia is, you know, you have your abdominal wall, you've got muscles, and then there are layers of strong connective tissue called fascia, and that's kind of what holds everything in. And so what a hernia is you develop a defect in that connective tissue layer, the fascial layer. So things that are supposed to be on the inside, like intestine, can start to bulge out. So, you know, they're still held in by skin and muscle, but that strong connective tissue is not intact anymore. So the concern is that you can have something that comes out into the hernia and gets stuck there. That's what we call an incarceration. So that's when something comes out and you can't push it back in, and it's just kind of stuck out outside of the abdominal cavity. So I think everybody can tell that that's not optimal. And typically that will present with a hard bulge that does not go away. It is severely painful. I mean, you really can't miss this. You would definitely know that something is going on, because it would be incredibly painful. And then eventually what happens is whatever is stuck out there it will continue to swell, and then you will eventually lose blood supply to whatever is stuck out in that hernia, and it can start to die off. Oftentimes it's just some fat that's stuck in the hernia, especially small hernias, but if it's intestine or something like that, that is obviously very bad, to have intestine that's dying off in your hernia. So that becomes really, truly an emergency, where you need to go to the emergency room and have your hernia fixed on an urgent to emergent basis. So that is definitely not optimal, and we definitely want to get it addressed before we get to that point, because you're going to get a better outcome, and, you know, shorter hospital stay if you take care of this more preemptively. So, you know, what is a hernia repair? Essentially, what we do is whatever is out in that hernia that's not supposed to be there, we put back into the abdomen, and then close that connective tissue layer, the fascial layer, and then in the vast majority of cases, reinforce that repair with a piece of mesh. This can be done in a variety of ways. It can be done as just a standard open repair, you know, with a large incision. It can be done laparoscopically, and nowadays a lot of people are doing these robotically, which makes a lot of the more difficult repairs just easier to do minimally invasively. So this, like the gallbladder surgery, if you're getting it done electively, you know, and I'm doing a robotic hernia repair, that is an outpatient procedure for the vast majority of hernias, unless you have a very large abdominal hernia that's involving your entire abdomen. But the vast majority of these will be done outpatient. And like I've mentioned, I do get this question a lot about mesh and the use of hernia repair. I'll just skip to that 1 sec. You know, whether it's necessary and is it safe? And, you know, a lot of people say, I've seen a lot of commercials about mesh complications. And, you know, what I tell people is that mesh really has been studied very extensively. And we do know that really for hernias of almost any size, so greater than 1 centimeter, you will have a better outcome with mesh. Your recurrence rate is lower, and you're just going to have a stronger repair, because when you have surgery, your tissue never heals back to 100% of its original strength. It will only heal to about 80% of the original strength. And if you had a pre-existing hernia there, we already know that there is some tissue weakness. And so just primarily repairing it or sewing that tissue back together in the majority of cases is probably not going to be optimal, and you're much more likely to have a recurrence. The mesh that we use, you know, is specifically designed for these types of hernia repairs. And, you know, we've had a lot of advancements in the type of mesh that we now use. There's a lot of different types of mesh, so I won't go into all of them, but, you know, they have all been studied extensively and proved to be safe. The rates of, you know, patients having like a mesh rejection or an allergic reaction are basically zero. That it's just not even reported in the literature. I mean, with any foreign body that you're placing, if you're having hardware like a joint replacement or something like that, of course, there's always going to be some risk associated with, you know, particularly infection, mesh migration, things like that. But those complications are low. I really very rarely see those. I can't tell you the last time I saw a mesh infection. It's been many, many, many years. So, the mesh is very safe. And so, if you're seeing a surgeon who does a lot of hernia repairs, the mesh is going to be the best option and have the lowest complication rate overall. Just wanted to go back for a second and talk about Da Vinci robots. So like I mentioned, a lot of surgeons are doing these robotically now. I do my gallbladders, hernias, appendices, all robotically. So it just depends, on the surgeon that you see, but the robotic hernia repair is a great option. The benefit of the robot is that, and of course, this is not, the surgeon is controlling the robot is not doing the operation. But essentially, this is the robot, and we insert the instruments into these arms, and they're controlled by the surgeon at a console in the room. And the benefit is that these instruments kind of articulate very naturally the way wrists do. So for a lot of surgeons, it's a much more natural way to operate. The incisions are small. They're usually 8 millimeters. So, very small. So recovery is quicker. And the robot is specifically designed to put less torque on the incision site so that you're not having the tissue trauma from, having a surgeon torquing instruments through the incisions and things like that. So, recovery tends to be faster with these robotic repairs. And, it seems like this is basically how, most surgeons are moving in the direction of doing robotic surgery at this point. So for a lot of these hernias, like I mentioned, can be done on the robot minimally invasively, in and out the same day. Surgery takes, maybe an hour and a half. So it is a great option for a lot of people. Recovery is going to be fast. So I would say for the vast, unless you really have a lot of medical comorbidities that are going to make surgery prohibitive, cardiac disease, things like that. I would say for any symptomatic hernia, I would definitely recommend at least looking into getting it repaired, because it will significantly improve your quality of life and reduce the risk of having complications down the line. And, I always do, I do these on patients who are on blood thinners, because what I tell people is it's actually preferable if we can plan in advance, to pause your blood thinner and do the surgery and then have you get back on it versus, waiting and then having it become an emergency where you get an incarceration or strangulation and you've taken your blood thinner that morning and then somebody's needing to operate on you and your blood thinner, is still in action. So it really is preferable. And, I always will have, especially if you have any cardiac history, we'll make sure that you get clearance from a cardiologist in advance. I have not had anybody who the cardiologist said, absolutely not. So there are very few contraindications to getting this done, if need be. I'm just going to touch on this. I don't do hiatal hernia repairs, but I do get this question a lot because people hear hiatal hernia and they think it's the same thing. I don't know if does anybody have a hiatal hernia here, been told they have one? Probably a lot of people actually have one, but you just don't know. But, some people will come and say, okay, well, I have 2 hernias. I have an abdominal wall hernia or an umbilical hernia and a hiatal hernia. The hiatal hernia is a completely different thing. So a hiatal hernia is essentially, when your stomach is herniating up through your diaphragm into your chest. And it's actually a lot more common than you would think. Like, I have a hiatal hernia, but in the vast majority of cases, it's just a small hiatal hernia. the usual presentation is that you have reflux, or, some sort of reflux disease or indigestion or something like that. And so the vast majority of times, these do not require an operation. They only require an operation when they're so large that, say, your entire stomach and colon are herniating into your chest or something like that. So these are different things. So just be aware of that. And the vast majority of time, if you're not having symptoms from it, you're not going to need a surgery for this. So, but I don't do these anyway. So, like I said, hiatal hernias, because that's definitely, for that surgery, you have to pull the stomach back down into the abdomen, out of the chest. You have to close the diaphragm. That's more extensive than when we're talking about for an inguinal or a ventral hernia repair. So you do want to make sure it's indicated if you're going to go ahead and have one of these repaired, and you want to have this done by somebody who does a lot of these. So if you ever are in a scenario where you are considering a hiatal hernia repair, I would just make sure that you're seeing a surgeon who does this procedure very frequently. So let's move on to diverticulosis and diverticulitis. Probably a lot of you have heard of diverticulosis. Is that a safe assumption? Okay, so it is very common in adults of all ages, but especially in older adults. And what is diverticulosis? Essentially, again, I'm sorry, this picture is very small, but in your colon wall, basically you can get these little outpouchings that we call diverticula. And it's basically it's kind of like a hernia of your colon. So there's like a little weakness in the wall, and so things kind of bulge out into this outpouching. Again, it is very common. It happens in young people, it happens in old people. I would say that the biggest risk factor for developing diverticulosis is chronic constipation, because having hard stools that are constantly putting pressure on the wall of your colon can lead to these types of outpouchings of the colon. Many times these diverticula are asymptomatic. And so there's nothing to do about them. The two most common things that can happen with diverticulosis are bleeding and infection, or an acute flare of diverticulosis. The bleeding is a very specific type of bleeding, because usually there's a blood vessel that kind of permeates the wall of this diverticula, and every once in a while it will kind of get irritated and it will bleed. So what patients will say is that they went to the bathroom, they were having a bowel movement, and the toilet bowl was just full of blood, like shockingly full. And, it's always really scary, of course. So I would say the majority of people end up going to the emergency room for that. But it will happen one time and stop. So that is the classic history for diverticulosis. Sometimes it will be the one episode and stop, but it can recur. So if this does happen, it is best to at least, if you're not going to go to the emergency room, to go see your doctor, because that may be sort of what we call like a herald bleed, where you have a little bit of bleeding and it stops and then it's going to come back later. So it's not really something to ignore. And oftentimes it can be controlled either endoscopically. So, the gastroenterologist can do a colonoscopy and kind of fulgurate that vessel that's bleeding. Or there's other ways to control the bleeding non-surgically. In the vast majority of cases for bleeding, you're not going to need a surgery unless it's so uncontrolled that you're needing transfusions and things. But that's not common. The more common thing that I see is diverticulitis, which is when one of these diverticula gets infected for whatever reason. Sometimes it can be impacted with stool or something. And so this presents as usually pain in the lower part of your abdomen, typically the left lower quadrant, but it can be really anywhere. Pain that doesn't go away, usually fevers, chills, sometimes changes in bowel habits, usually diarrhea, but that would be the typical presentation. And essentially, if you were to go to the ER with that and you got a CT scan, they would show that there is some inflammation of usually it's your sigmoid colon that is affected. If it is a simple case of diverticulitis, that can be treated with antibiotics. So you'll usually be inpatient for a day or two, getting IV antibiotics while we kind of see how you're doing. And then if you were to continue to progress clinically, you would go home on oral antibiotics for a period of time. And, for some people, they'll just have that one episode and they will never have another one. For some people, they can continue to have recurrent episodes. The other way that diverticulitis can present is as a more complicated diverticulitis. So that would mean that there's been some sort of perforation of that diverticula. So essentially the diverticula burst, and now you have either, frank contamination, stool, or you may have developed an abscess in your abdomen somewhere. And so there are varying degrees of what we call of complicated diverticulitis, but typically the treatment for that, again, if it's a small perforation that has contained itself, the treatment may still just be IV antibiotics, probably for a longer period of time. But if you're having, frank spillage of stool or what we call peritonitis, that is something that would require more of an urgent or emergent surgery to control that contamination and remove that portion of the colon. That doesn't happen all that often, to be honest with you. I really don't see that all that much. What I see more commonly is that there is what we would call a contained perforation. So this little diverticula burst causes an infection and there's an abscess now, near the colon or in the pelvis or something like that. And, depending on where that abscess is and how big it is, there's various ways to treat that. But a lot of times that can be done non-operatively as well. So, there are the vast majority of cases of diverticulitis that I see do not require surgery. Like I said, if you're having really peritonitis would be an indication for surgery, or if you're being treated with antibiotics and you're not getting better, and things are just going in the wrong direction, that may be an indication for surgery. Or for people who are having repeated episodes of complicated diverticulitis, to where they're needing to be hospitalized every few months with another episode, or something like that, then that is a time when you would want to discuss potentially moving forward and just maybe electively having that portion of your colon removed to avoid those episodes in the future. Sometimes I recommend it for people also who are planning to travel extensively and you may not be near health, in an area where there's readily accessible healthcare or healthcare that you trust. So in those scenarios too, you might want to consider surgery. Really, for all of these conditions, I think that's safe to say is, if you're frequently in an area where you're not going to have access to healthcare, it may be a good option to go ahead and get some of these problems taken care of when you have the opportunity closer to home. Appendicitis, I think, I'm not gonna linger on this because appendicitis pretty much almost 100% of the time should be treated operatively. So if you go to the hospital and you have appendicitis, chances are you're going to get an operation, unless you're so sick with something else, like you also at the same time are actively having a heart attack, in that scenario or something like that, the surgeon may opt to treat it non-operatively, but the vast majority of the time you're going to get a surgery for this. There was a time when people were discussing treating appendicitis with antibiotics alone, and there was some data that could be successful, but that's really not the standard of care because the recurrence rates are obviously much higher if you don't remove the appendix. And there is a small chance that appendicitis can actually represent an underlying neoplasm or cancer of the appendix. And so if you're going to treat the appendicitis with antibiotics, you will miss that because you will not be sending the appendix to the pathology lab to be examined to find out that it was in fact a cancer. So appendicitis, I definitely always recommend surgery. And then last thing I'm going to talk about are just some benign skin lesions, mostly lumps and bumps. The most common thing I see is what's called a lipoma. And you can see what that is. It's basically a benign fat tumor. So it's just an overgrowth of fatty tissue in this kind of capsule, and it presents as like a lump, on somewhere on your body where you have fat. It'll be soft. Usually you can move it around. In most cases, these are painless and asymptomatic, but sometimes if they're either enlarging rapidly, because there is a very, 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 very small chance that this could transform into something malignant. I don't think I've ever seen that, but in theory, there is a small chance. So if it's enlarging quickly, or if it's causing pain or discomfort or somehow affecting quality of life, like I took one out of a patient, it was about the size of a grapefruit on her thigh. So, she had to buy different sized pants and things because she couldn't fit it over her pants over this mass, In those cases, then it's definitely reasonable to consider removing these. And this is a very straightforward procedure. I mean, if it's really tiny, it may be able to be done in the office, but most of the time I recommend doing it in the operating room just so that you can have some sedation, and in case it's a little deeper than expected, you're not having discomfort. But the vast, vast, vast majority of these are going to be benign. So the only reason to remove them is if they are bothering you. I also do know that insurance actually doesn't even cover removal for cosmetic reasons. So I always document in my note that there is causing pain. So yeah, so you do have to say that if you want to have it removed when you see a surgeon, that it's painful. So, and then, most of these can really be diagnosed on physical exam. If there's any question, I will usually order imaging, either an ultrasound or an MRI, just to make sure that there's no other structures involved, or that we're not looking at something else, like a liposarcoma or something like that. But the vast majority of time, it's going to be very obvious on exam. So just to recap, just some things that you should definitely be asking your surgeon when you're seeing them. Hopefully they're volunteering the risks and the benefits of the operation, but if they are not, you should definitely be asking about that, right? Because it's important to be fully informed if you're going to move forward with any of these procedures. You want to know how long is recovery, what will be my restrictions afterwards in terms of weightlifting or activity, what are the possible complications that I can expect. And then, you always do want to know what the alternatives are. Like I mentioned, there may be non-surgical alternatives for some of these conditions. Just because a surgeon is recommending that you have surgery doesn't mean that you need it. So it's always best to just ask these questions and be aware yourself, and come armed with some knowledge so that you have some idea of what's best for you. And then I didn't put this on here, but I do recommend that you do some research into the surgeon that you're seeing. Ask them, how many of these procedures have you done, especially if it's not something straightforward, because you do want somebody who is experienced, and like I said, for hiatal hernias and things like that, especially, or very complicated hernias, I will refer patients, elsewhere if that's outside my area of expertise. So you definitely want to make sure that it's somebody who is familiar, or very familiar with the procedure that they're doing. And then just some key takeaways that we talked about. A lot of these conditions can be managed non-operatively, but that being said, there are a lot of reasons why surgery might be recommended. And, I think there is maybe this thought because surgery used to be much more invasive with a longer recovery time, that, surgery should be avoided in older adults or if you have a lot of medical problems, but that's really not the case these days. So in the vast majority of people, surgery is going to be safe, and it can significantly enhance your quality of life and reduce your risk of long-term complications. Thank you. So I think we will move on to the Q&A now, and this is my contact information. If you have any of the above mentioned conditions.
Great. Thank you so much, Dr. Butler. So, and that was very informative about different procedures, and I love that. I had a couple of questions come in. One was regarding appendicitis symptoms. Can you experience those before it becomes a medical emergency?
Yes, so you definitely can. And the classic presentation of appendicitis is people will say, well, I had pain around my belly button for a day or two. Most people blow that off as like indigestion. And then it will move over to the right lower quadrant and then become severe. So that is the typical history for appendicitis, but some people have different symptoms. Sometimes people say, I just had nausea, vomiting, diarrhea, or they just felt like they had some sort of stomach bug. I also have seen cases of kind of long-term chronic appendicitis, where people had symptoms that kind of came and went and ultimately ended up being appendicitis. That is a lot less common. But definitely for appendicitis, if you're thinking you have appendicitis, I would say just go to the ER, because the longer you wait, I saw somebody who came to the ER. She had started to have the pain, thought it was nothing, got on a plane from Singapore, flew here from Singapore, was carrying luggage around and everything, and then all of a sudden, could barely move. So that's not ideal. So, and she had a very, very bad perforated appendicitis. So it's always best to get to it early. So if you're thinking I might have appendicitis, just go get it checked out.
Okay. Can you talk a little bit about umbilical hernias?
Sure. So umbilical hernias are in that category of the abdominal wall hernias I was talking about. They can be congenital. So probably a lot of people have heard of like babies who have umbilical hernias that need to be fixed. But in adults, they're more often than not acquired. We just, we have a natural weakness in our abdominal wall at our belly button because our belly button is there. And so over time, people can just develop an enlarging area or defect there. And, I don't know why it happens to one person over the other. I've never really, there's really no risk factor that I can think. People always say, was it because I lifted or something like that? And the answer is no. I mean, that may have made it more prominent or made you notice the symptoms, but at the end of the day, some people just get umbilical hernias. For those, it's the same sort of thing. I mean, if you're having no symptoms from your umbilical hernia, it doesn't bother you, it's not painful, you don't mind it, you really don't have to get it fixed, as long as you are aware of the symptoms that would necessitate getting it evaluated, like worsening pain or an enlarging hernia. But, I would say that for most people, they're going to have some sort of symptom from their umbilical hernia. And some people just don't like it. So that's another reason to go ahead and get it fixed.
Okay. And you had mentioned blood thinners, but are there other medications that may be common that older adults are taking that can affect their surgical procedure?
Blood thinners for sure. I mean, and that includes aspirin. I actually like aspirin the least, and Plavix of all. I would take Xarelto or Eliquis any day over one of those, because those have a really short half-life and they're out of your system pretty quickly. But those are really the big ones for me. there aren't really any other medications I can think of that would necessarily be a contraindication to having surgery. Typically, if you just have an exhaustive medication list, that's usually just a sign that you maybe have a lot of medical problems in general. But no, I can't really think of any other specific medications that would necessarily make surgery, contraindicated or less indicated.
Okay. And how about side effects? Side effects that are common after these surgeries that older adults may be at higher risk of having. Are there any specific ones maybe for older adults?
Sure. I mean, I would say the biggest one, especially if you're having a more major, like an abdominal surgery, that I always worry about would be, pneumonia, blood clots, and infection. Typically for my outpatient procedures, you're getting up and going home and you're walking around. So I don't see a lot of pneumonia and blood clots after those. But let's say you're getting an emergency surgery or you're an inpatient in the hospital, then you will be at higher risk of those. And that's why it is important. One, that's why another reason why it's better to get some of these issues taken care of electively. When you're going to be able to be in a better position to be mobile post-operatively. But those are always big ones that can really prolong hospital stays and make recovery more difficult, make it more likely that you would need to go to a rehab or a skilled nursing facility after the operation, something like that.
Okay. The last thing, somebody is asking about hip surgery. I'm not certain that you do hip surgery, so I want to just ask. So in case you do.
I do not do hip surgery.
I didn't think so. That would be more orthopedic.
Yeah.
So for instead of general surgery. I do want to also just share with everybody again, sort of your phone number and where you're located. I know you said you are you're just across the hospital or right across from the street from the hospital, right?
Mm-hmm.
Off of Wyatt. Is that correct?
Correct. It's in the same, I think it's where the physical therapy is as well. It's right adjacent to that. Yeah.
Okay, great. So
yeah, because I go in that door and I always see people in the pool.
Okay.
Doing their physical therapy. So
okay. So if you're interested in an appointment, please call 520-420-2270. If you would like an appointment, I'm assuming a referral is required, correct? When they make an appointment to see you?
I don't think so, actually. I think not from scheduling with me necessarily. From insurance standpoint, it may be.
Yeah, I know most of them do require some sort of a referral. So that's why I mentioned that. So maybe check if you need to get a referral or not. I want to thank you so much for being here today, Dr. Butler. This was great. It was a great overview. It really provided a lot of information for folks who may need to have some of these procedures in the future. I am going to wrap up with our online audience and I will turn it over to you for anything in person. Thank you again for being here.
Good. Thank you.
Thanks again for joining us today. We hope you'll come back tomorrow. We will be doing another presentation. This is part of our survivorship series. It is Understanding Your Options, Navigating Breast Cancer Care. If you're interested in joining us for that class, the phone number is 520-324-1960, and we'd be happy to help get you registered. We look forward to seeing you soon. Thank you.